One study followed patients with knee arthritis who received subchondral in the bone, BMAC, bone marrow aspirate concentrate, injections for 15 years. At the end of that follow-up, only 20% of those knees required total knee replacement. The intra-articular, just in the joint, injection group, 42%. That is a real number from a real published study, and it's exactly the kind of data that should be part of every conversation about knee arthritis before anyone schedules surgery. Today I'm going to walk you through 10 years of BMAC evidence, the real data, the honest limitations, and what it means clinically. I'm Dr. Trevor Turner, interventional sports and spine physician at Pravida Health in Atlanta. I'm PM&R board certified, and regenerative joint injections are a core part of my clinical practice. I want to be upfront. I use BMAC clinically, but I also think the stem cell industry does patients a disservice when it overpromises. So in this video, I'm going to give you the evidence accurately, including the study that showed BMAC is no better than cortisone at 12 months, because that study exists and you deserve to know about it. The truth is more nuanced than either side of the debate usually acknowledges. Let's start with what we're actually injecting. Bone marrow aspirate concentrate, BMAC, is your own bone marrow, harvested from your iliac crest, here on your lower pelvis, concentrated by centrifugation into a biologically active product. What makes it interesting isn't any single ingredient, it's the complexity. You get mesenchymal stem cells, MSCs, which can differentiate into cartilage, bone, and fat cells, and more importantly for osteoarthritis, they produce powerful anti-inflammatory paracrine signals. You get platelets with growth factors, PDGF, TGF-beta, VEGF. And critically, you get interleukin-1 receptor antagonist, which directly blocks the primary inflammatory pathway that drives cartilage destruction in osteoarthritis. Research shows BMAC contains significantly higher IL-1RA levels than PRP alone. In native bone marrow, MSCs represent only about 0.001% of nucleated cells. That's why concentration matters, and why the equipment and technique used directly affect how many cells are actually in the syringe. The short-term data. A December 2024 systematic review in the Orthopedic Journal of Sports Medicine, 8 RCTs, 937 total patients, found BMAC significantly improved pain compared to hyaluronic acid at both 6 months and 12 months. No serious adverse events in any arm. A 2025 review in the Journal of Orthopedic Surgery and Research confirmed intra-articular BMAC improves functional outcome scores at 6, 12, and 24 months versus baseline, with statistically significant results. The long-term data, this is where it gets compelling. Multiple studies with 5 to 15-year follow-up have tracked what happens to BMAC-treated knees over time. The 15-year subchondral injection study, 20% total knee replacement rate versus 42% for intra-articular, is the headline number. A separate 12-year study in bilateral osteoarthritis from corticosteroid-induced osteonecrosis, 30 knees treated with BMAC versus 30 with total knee replacement. Knee score, no significant difference, but only 3 of the 30 BMAC knees ever needed surgery. The MILES trial, the honest version. Now here's the study everyone cites against BMAC, the MILES trial, published in Nature Medicine in 2023. 4 arms, 480 patients, 4 study sites. BMAC versus adipose, fat-derived, SVF versus umbilical cord, MSCs versus corticosteroid injection. Result at 12 months, all groups improved. No group was dramatically superior to corticosteroid. Duke Health summarized it fairly: MSCs are a safe treatment, but MSCs are not the fountain of youth they are often portrayed as. Here's what MILES does not tell us. 1. It used a single injection protocol. Most of the compelling BMAC data uses optimized injection technique, subchondral delivery, not just intra-articular. 2. It followed patients for 12 months. The total knee replacement avoidance data that's most compelling is at 5 to 15 years. 3. It did not stratify by cell count or quality. The dose dependence data is clear. Patients with less than approximately 2,000 CFUs per milliliter of MSCs respond poorly. MILES didn't account for preparation variability. MILES tells us a single BMAC injection is safe and performs at least as well as cortisone at 12 months. That's meaningful. But it doesn't close the book on BMAC for the right patient at the right dose over the right time horizon. In our CardiNova protocol, BMAC isn't just inject and hope. It's a precise clinical process. We verify MSC concentration before and after injection. We use ultrasound and X-ray guidance for both harvest and injection. We select patients carefully, KL grade 2 or 3, with BMI under 40 and appropriate anatomy. And for the right patients, we use a combined subchondral and intra-articular delivery approach, which the long-term data consistently shows outperforms intra-articular alone. Who is not a candidate? Advanced grade 4 OA with complete joint space loss, severe varus or valgus deformity, active joint infection. These patients need surgery, and we tell them that. The FDA classification matters here too. Autologous BMAC, your own bone marrow, is classified as a 361 HCTP under FDA regulations. It doesn't need drug approval because it's minimally manipulated autologous tissue. That's a different category from allogeneic cell products, exosomes, or other things being sold as stem cell therapy. When a patient asks me, is this FDA approved? The honest answer is, autologous BMAC doesn't require FDA approval in the same way a drug does because it is considered to be the practice of medicine. It requires a qualified physician, proper technique, and honest patient selection. That's what we do. If you're dealing with knee osteoarthritis and you've been told your next step is a knee replacement, I'd encourage you to have a full conversation about orthobiologic options before you schedule that surgery. Not because surgery is always wrong, but because it should be the last resort, not the default. And for the right patient, the evidence for BMAC, particularly over a longer time horizon, is more compelling than most orthopedic surgeons will tell you. The link to schedule a consultation at Pravida Health is below. If you found this useful, subscribe. We do this every week. See you next time.